Oh, there we go. All right, that's me, Bill Adams. Great to be here. Thanks so much for inviting me. I'm a pediatrician over at Boston Medical Center, and I also lead the informatics work for the Boston University Clinical and Translational Sciences Institute. I work within an extraordinary ecosystem that involves the largest safety net hospital in New England, actually, and an incredible group of community health centers that have been trying to improve and deliver healthcare for urban Boston for many, many years. And we also have some very extraordinary, which I would say underutilized data available to do research and better understand the health and healthcare of folks living in Boston. We've also come to realize, like probably all of you, that there are many more things that determine health than the healthcare that people receive. This is just one estimate that about 16% of our health is determined by the healthcare we get, the clinical care we receive, and so many other features are relevant to predicting and understanding health. And we've generally not been able to bring those predictors or those variables together with the clinical data. We've mostly focused on clinical care and health outcomes within the electronic data systems we have. So what I wanted to try to excite you about today is an rapidly evolving opportunity to use data in collaboration with us over at the medical campus to study much more than just clinical outcomes and to bring social determinants of health into the studies and work that we do. And this is all in tight collaboration with the new Boston Medical Center Health Equity Accelerator. So this was launched just 2 weeks ago. It's very fresh. BMC, Boston Medical Center, and the overall health system is deeply committed to advancing health equity, not just for patients, but across the institution, from everyone who works there to the people we care for, to the community that we serve. And we're especially interested in these domains: maternal and child health, infectious diseases, behavioral health, chronic conditions, and cancer. And there are 4 core pillars up here on the right. One is clinical care. The work that I do mostly is focusing on the research and education piece, and particularly relevant is our work in data and aggregating data for the network. And then we also have a deep interest in community and SDOH work and policy and advocacy. So this is part of a very large effort, but we believe that data and clinical data and community-based data is going to be critical to success. For those of you who are data scientists, we've embraced the Odyssey community and the health services data model, common data model that's being promoted by Odyssey. This is a national group that builds software, collaborates nationally, and is just a wonderful community to work and do research in. And they have a rapidly evolving focus on health equity. So the work that we're doing is not only going to be relevant to Boston and the BU community, but this will tie in very tightly with a national community that's really looking to learn from us and for us to teach them. And at the base of this is a common data model, which, if any of you have worked with electronic health data, it can be quite complex. Some models are fairly genetic and can absorb any type of data, tend to have a more vertical format and hard for ordinary smart people to use. The common data model for OMOP and Odyssey, you can look at the tables and sort of begin already to get a sense for what data would be in those tables. And we think it offers a much more accessible common data model for data scientists. It is de-identified, so we protect patient privacy very, very aggressively. And our thinking with the larger Odyssey community is to bring in, so we map by zip code and census tract all the places that people live at the time that they register for visits. So for a very large 1.4 million population, we know where in Boston they live and when they lived there approximately. So we're able to link a huge number of variables potentially with the places that people have lived. So all of a sudden you can see that the data system, the health system actually becomes the measure of health, but only covers a limited range of variables that predict that health. And we're able to build out that model tremendously. We still, with this model, don't know enough directly from patients about their personal experience, and that probably is 3.0 that's coming. But if we could bring together the clinical data and rich location-based data into a generally easily accessible format, we think that we could really support that. So we invite you to start to work with us. You can see up here, it's the number 2022. So this is just coming online this month, December. And so next year is really where we're starting to look for partners to help use the system. And it's going to include 20 years of integrated clinical data. It's going to combine health centers and BMC. It's going to have rich location-based data, a much better data governance structure, shared software, a national community to participate in, and the opportunity to do all kinds of machine learning, artificial intelligence, comparative effectiveness, and health services research. And I'm out of time. So thanks for listening.